So over to you, Shagun.
Yeah.
Just a second. Good evening, everyone. I hope I'm audible.
Yes.
Yeah.
Yes, Shagun.
So, on behalf of SFM, yes. So on behalf of SFM, I welcome you all to this second episode of the Executive Committee webinar series. So today's episode is going to actually focus on the practical nuances of genetic tests in the fetal medicine clinic. So we are going to have 2 sessions, and in these sessions, we are going to have expert interactions in the form of 3 talks and a panel discussion. And we are trying to we're going to kind of understand what are the various advanced genetic tests which are now available, and how we can use these tests, when we should be using, and why we should be using them in the fetal medicine practice. So we hope that through this webinar, everyone would feel confident enough to kind of really order the correct genetic test in their day-to-day practice, and we can together optimize the outcome for the fetus. So for the first session of this webinar, we are going to have 2 moderators. So these moderators, of course, need no introduction. These are really the heart, mind, and soul of SFM. So we have Dr. Ashok Khurana and Dr. TLN Praveen. So over to you, sirs, to take over this session.
Thank you, Shagun. And it's a pleasure to be on here tonight. Thank you so much for organizing this. For those of you who are not familiar with our webinars from the Executive Committee of the Society of Fetal Medicine organizes these once in a month for the last couple of months. And we bring to you ideas which are fresh off the press, so to say, because we really believe that some of us are now over the hill, and we should hand over the platter as well as the baton to fresh minds. And it's so nice to have so many people attending here already in what is going to be pure genetics. We have understood that, yes, there is now the basis of genetics, which has been replaced not by fancy stuff we pick off the internet, but from an ultrasound phenotype. And yet we have places where ultrasound doesn't play that much of a role. But it's so nice to know that we have here this evening people from radiology, people from obstetrics, and people from fetal medicine get together with genetics to do this. And that is really the purpose of the Executive Committee webinars. Today, we're going to have some very interesting sessions. And the one I'm going to introduce you is our prime session for today. We have Antoni Borrell, who's going to speak to us on the promises and challenges of NIPT in clinical practice. For those of you who don't know Antoni Borrell, I think you should hang yourself in shame and never be seen on the planet. If you have ever done an intelligent Google search or a PubMed search and you haven't come across his name, then you haven't done your search properly. It doesn't matter what topic you choose, he will always be there. He had his beginnings, of course, at Queen Charlotte's in Chelsea in London, if you want a formal introduction. I went on to Karolinska, also Brigham and Women's and Mount Sinai, so the big names. But that's not the important. The important part is that he is the big name who is now bigger than all those institutions. A, because he has the most fantastic research to his credit, the most fantastic guidance to his credit, and equally importantly, such a wonderful human being. Thank you so much, Tony, for being here this evening. It's very kind of you to agree to this, and we're all looking forward to your presentation and then some question answers on the promises and challenges of NIPT in clinical practice.
Thank you very much for this nice introduction, which is a little bit exaggerated, as you will see. I will deal with this topic, cell-free DNA testing in clinical practice, promises and challenges. I'm just starting to remind that aneuploidy screening started in the 70s or 80s, just asking women how old they were. It evolved to the second trimester biochemical screening in the 90s, to the first trimester combined test in 2000. And in the last decade, cell-free DNA testing has been introduced into clinical practice. You know that we have two names to call it, cell-free DNA or non-invasive prenatal testing and NIPT. And I would give you some reasons to abandon NIPT and call it cell-free DNA. The first reason is that all screening tests are non-invasive prenatal testing. So if you have a look to those methods of screening that have been used in the last decades, all are non-invasive prenatal testing. So what's the new thing? The new thing, it's not that a screening test is non-invasive. All are non-invasive. The invasive are the diagnostic tests. The new thing is that we check or we study the cell-free DNA in the maternal circulation. This is an advanced screening test. It's not still diagnostics, but it's an advanced screening. In this talk, I will deal with three main points. The first is performance of extended cell-free DNA once we expand from typical trisomies to sex chromosome anomalies, atypical trisomies, deletions, duplications, or microdeletions, microduplications. The second point will be the application of cell-free DNA testing in specific types of gestation, such as twin pregnancies or assisted conception pregnancies. And finally, we will discuss different strategies of clinical cell-free DNA application in case of ultrasound anomalies as a primary screening, as a secondary screening, as a contingent screening. So let's start with the extended cell-free DNA testing. Initially was proposed to study the typical trisomies, 13, 18, 21, but soon it expanded to determine sex and also to study sex aneuploidies, mainly in the private sector, because in the public countries where it is used in the countries where it is used in the public health services, sex aneuploidies are not studied. Then also to atypical trisomies, so trisomies that are not 13, 18, 21, to deletions duplications, the large deletion duplication that can be seen in a karyotype, also to microdeletions, microduplication, the small deletions and duplication that cannot be seen in a karyotype, and finally to selected monogenic disease, but we will not deal with this point, that is still experimental. So to start with, I would like to remind you that genetic disease can be subdivided into three main types: chromosomal anomalies first, microdeletions, microduplications as the second type, and monogenic disease as the third type. Chromosomal anomalies are those large anomalies that can be seen in an optic microscope, when we see that there is a whole chromosome extra or a whole chromosome missing or a big part of it. Half of the chromosomal anomalies are trisomies 21, which are very common. And 1/4 are the typical trisomies. Trisomy 18, trisomy 13, and also sometimes we can consider monosomy X also as a typical anomaly. And finally, the atypical anomalies are those that are not these three or these four anomalies. Let's start to analyze the performance of cell-free DNA when they screen for typical trisomy. And I would like to bring you just a single paper rather than meta-analysis, because most of the papers that have been published on cell-free DNA for typical trisomies, they are published by the industry, and there were some cases selected, not in the first trimester. So I think this is, in my opinion, the seminal paper is this, Trident 2, which is a public program in Holland when they offer cell-free DNA screening as a primary screening to any pregnant women. And these are the results in relation to the typical trisomies: 0.5% of screen positives. And when they had, and also this is very important point, many studies published, they have not a full perinatal outcome. Here the perinatal outcome was more than 97%. And when we will analyze the performance of cell-free DNA, we will use these parameters. We will use the screen positive rate, meaning that this is the proportion of cases that are screen positive among all the screen cases. Here we can see that for trisomy 21, the screen positive rate is 0.33%, so less than 1%. Remember that the combined test was about 3%. So this is 0.3%, 10 times less. And for trisomies 18 and 13 is 0.15%. So definitely figures very low screen positive rates. And the other value that we will compare when assessing the performance of cell-free DNA will be the positive predictive value. Or let's say this is the proportion of confirmed cases among the screen positive cases. So if we have a 96% positive predictive value, means that if you get a positive result, the chances of being a true positive is 96%, so very high. In a trisomy 13 or 18, if you have a positive result, the chances of being really positive is 74%, intermediate. Remember that for the combined test, the positive predictive value was about 10% or maybe 5%. So most of the cases with a positive result, they turn out to be a false positive. And finally, the detection rate. The detection rate is the sensitivity. The sensitivity is how many affected cases can be picked up by this method. This is a parameter that is very interesting for the direction for the government or for the health department, because they know how many cases are picked up. But for pregnant women, they are interested for the positive predictive value, which is her own value. So here in this series, the detection rate of trisomy 21 is 98%, which is high, but maybe it's not so for 99.9 that sometimes the industry have shown these papers on 99. No, it's 98. And for trisomy 18 and 13 is 96%. I think this is a real seminal paper. What about sex chromosomal anomalies? The first question is, should sex aneuploidies be screened for? And probably our reply would be no. Why? Only in cases of abnormal ultrasound. I mean, everyone that is dedicated to clinical genetics know, I mean, the problems that we have when a couple comes with the diagnosis of a XXX, double Y, or Klinefelter. That is very difficult to counsel and say it's not so severe, and many of them they want anyway to have a termination, being a mild syndrome or mild situation. Anyway, if we perform cell-free DNA to screen for sex chromosomal anomalies, these are the figures of a recent meta-analysis. This is a meta-analysis. I think there is only one, has been published last year, with more than 325,000 cases, detecting or including more than 1,700 sex chromosomal anomalies. Here we can see the screen positive rate. The screen positive rate is relatively high. Remember that for trisomy 21 was 0.3. In this case, it's 0.6%. And the positive predictive value is not very high. It's 48%. So only half of positive cases are confirmed after an invasive procedure. And it depends on the aneuploidy, because you can see here in this part of the table that monosomy X is confirmed only in a third of the cases, 31%, while the other aneuploidies are confirmed in a 60, 70+% of the cases. So finally, we will analyze what happened with cell-free DNA in the screening for the atypical. So the other fourth of chromosomal anomalies that are not these four anomalies are the atypical chromosomal anomalies. They can be atypical autosomal trisomies, full autosomal trisomies, or can be partial trisomies. That this would be a duplication, or can be a deletion. So instead of extra material, to be missing part of a chromosome. That can be seen, remember that a deletion duplication can be seen in an optical microscope, can be detected by a karyotype. Microdeletion, microduplication is not detected in a karyotype, should be a microarray, should be. And for assessing this performance, I've chosen these two population studies, not only in Holland, that they are using cell-free DNA as a primary screening, but also in Belgium, that also they are using cell-free DNA as a primary screening. Here we have the numbers, high numbers, 224 pregnant women from the general population with a full follow-up. And here is the screen positive rate. We have already the screen positive rate for a typical trisomy. So it's low, it's 0.2% only, not much. And for deletions, duplications is 0.15%, also low. Remember that for typical trisomies together was 0.5%. And the positive predictive value is surprisingly low for a typical trisomy, 5%, like the combined test, 5%, 1 in 20. Still is high because it's 1 in 20, but it's low compared with the positive predictive value for all the other anomalies. Finally, the positive predictive value for deletions, duplications is intermediate, 40%, almost half, sorry. The detection rate was not assessed in this population study. It has been assessed in this smaller study from Australia, and it seems high for a typical trisomy, is 96%, so they can pick up most of the typical trisomies. And for deletion duplication is low, as expected, 74%. However, cell-free DNA testing used for detecting atypical trisomies is very controversial nowadays. It appeared last year, an opinion commentary in Ultrasound Abnormalities and Gynecology by some prominent European professors, pointing out the uncertainty after a positive atypical trisomy result, either if it's confirmed or not confirmed. Also pointing out that there is an increase in false positive and invasive testing rates, that this is not recommended by scientific societies, that it raises ethical and legal challenges in how to counsel these cases. And finally, they consider to use this cell-free DNA testing that it's called genome-wide cell-free DNA testing, because we are testing for all the chromosomes, not only for 13, 18, 21. They consider this as a violation of WHO screening principles. This letter or this opinion was replied by this group of scientists in Holland, and they state, or they argued that when they offer genome-wide cell-free DNA, meaning also the typical anomalies to pregnant women, 78% of women prefer to do the genome-wide cell-free DNA rather than only the typical trisomies. Then a typical trisomies carries an increased risk of adverse outcome between 20 and 50%. That 39% of the typical trisomies cannot be detected by ultrasound. That genome-wide cell-free DNA can detect some maternal malignancies, and that the excessive invasive testing is not as much as for other tests, only 0.4% of excessive invasive testing. And finally, that they confine this result to be delivered only by clinical geneticists. Here, this is a systematic review and a meta-analysis performed by Peter Ben and Francesca Gratti to demonstrate that to screen for atypical trisomies using cell-free DNA is useless. And they bring all these papers together, and they got 192 cases of atypical trisomies detected by cell-free DNA. And they find out that only 9% of those cases are confirmed. In this case, it's a little bit higher than the 5% that we were quoting before. Between 5, you see, between 5 and 9%. And they say it's useless because only 9% of those cases are really the trisomies are present in the fetus. But using the same table, I argue exactly the opposite, because if you can see here, only 41% of those fetus are apparently normal live born because there is a 27% pregnancy loss, 7% abnormalities in the phenotype, 2% of uniparental disomies, significant uniparental disomies, 15% of fetal growth restriction, and 0.7% maternal malignancy. So it is true that the precise trisomy is confirmed in few fetuses, but also it's true that most of these pregnancies are not normal pregnancies. Let's move to the other type of genetic disease, microdeletions, microduplications that are not seen in a karyotype, and they can be as frequent like the chromosomal anomalies, and that they can be detected by microarray. Microarray can detect the chromosomal anomalies and microdeletions, microduplications, but they don't detect, it doesn't detect the monogenic disease. Here, also last year, appeared one systematic review and a meta-analysis, only using this 1, 2, 3, 4, 5, 7 series of cell-free DNA applied to detect microdeletions, microduplications. Among these 7 series, 5 were dealing with any microdeletion, and 2 studies were focused to detect selected microdeletions. And the screen positive rate is not high, it's 0.19%, so relatively low. And the positive predictive value is intermediate. So only 44% of the positive cases are confirmed in the field. So I would like to state which are the conclusions of this first part. This is a table of summarizing all those numbers. Sorry for so many numbers, but to analyze the performance, I need percentage, I need rates. And we can conclude that analysis of cell-free DNA in maternal blood has shown to be highly specific and sensitive method to screen for typical fetal trisomies, that the observed screen positive rate, SPR, is low for all the different types of anomalies, between 0.15% to 0.13%, with the exception of sex chromosomal anomalies that have a screen positive rate of 0.6%. And finally, the positive predictive values are high for typical trisomies, 74 to 96%, low for atypical trisomies, 5%, and intermediate for the remaining anomalies. I personally consider that those 2 large country-wide studies performing the general population in Belgium and Holland, they validate the use of cell-free DNA in detecting atypical anomalies. Maybe we are not in this position according to microdeletions and microduplications in which the experience is much reduced. Let's move to the second point. How is working cell-free DNA in specific types of pregnancy, such as twin pregnancies? And this year, surprisingly, have appeared 3 meta-analyses on how cell-free DNA is performing in twin pregnancies. And if we add all the studies, all the reported studies together with the 3 meta-analyses, we got 19,000 twin pregnancies with 148 trisomies 21. And here are the detection rates achieved. So the detection rate is 98.6%, so no different than in singletons. And for trisomy 18, 92%, 0.6. and for trisomy 13, 91.6%. So the figures are really good. The screen positive rate is higher, that in singletons is 2.4. And also, what is higher is the failure rate. This is one of those large studies. This is the Belgium study, including only in this study 4,000 twin pregnancies in which cfDNA was studied. This is in Belgium. This is a population study with full follow-up, and they had relatively high failure rate, about 5%, but only 1.2 after resampling, and the screen positive rate for typical trisomies was 0.6, a little bit higher. For atypical trisomies was 0.3%, and the positive predictive value was lower than in singleton, but we have to understand that this is a reduced sample with not so many Down syndrome. The number of Down syndromes here are just 11, because it's a low-risk population. What about IVF pregnancies? I have more questions than answers, and I cannot respond properly any of those questions that I've made to myself. Is cfDNA testing less accurate in IVF? And I found some series in which they found that the median fetal fraction was lower. The fetal fraction means the proportion of cfDNA in the mother, which is of fetal origin. Usually it's about 10%. So about 10% of the cell-free DNA, understanding that cell-free DNA is all the DNA that is present in the maternal plasma outside of a cell. It's cell-free. It's not inside of the nucleus, not inside of the cytoplasm. It's in the plasma alone. So among all the cell-free DNA in maternal plasma, usually 10% is of fetal origin and 90% is of maternal origin. So there are two series that they have found that the fetal fraction in IVF is lower than in natural conception. But there is another study that they didn't find any difference. And finally, the second question is, cfDNA testing is the elective test to confirm PGTA? And definitely I have no answer. PGTA, pre-implantation genetic testing, especially with regarding aneuploidies, is now very, very precise, very accurate. There is some rate of error or mistake. They say many of the report, they say this is a screening test. You should confirm this with the prenatal diagnosis. But still, we don't know if we have to confirm all the cases. In first trimester screening is the correct screening of those cases, or cfDNA. What we know by certain is that if we apply cfDNA testing in cases of IVF after PGTA, the positive predictive value is low, is very low. And finally, the third point I would like to deal with is the different strategies in which we can apply cfDNA testing. We can apply cfDNA testing in ultrasound anomalies, very high risk. This is not indicated. In high-risk population, instead of offering an invasive procedure, we can perform cfDNA testing. This is called secondary screening because this is the second screening after the combined test. We can use it instead of the combined test as a primary screening in the general population, or we can use a contingent screening that we will explain a little bit more in intermediate risk. First point, in very high risk, for example, in increased nuchal translucency, we have shown in a paper that cases of an increased nuchal translucency higher than the 99th percentile, 36% of the cases, they are due to a genetic anomaly, is in blue. And among these genetic anomalies, 12% cannot be detected by conventional cell-free DNA test. So we don't recommend cell-free DNA testing in those cases. Also in an ultrasound anomaly, we recommend a CBS or an amnio plus a microarray. As a secondary screening, the main point is to avoid the risk of invasive procedures, which is the discomfort, but the main problem is fetal loss rate. However, fetal loss rate that was quoted 1% during many years has been recently analyzed by different meta-analyses and now is about or up to 0.3%. Minus 0.1 cannot be. I mean, this is like an artifact, but definitely it is lower than years ago, and it's clear to understand because the machines are better and we are better also with the needling. Recently, there is only, in the old times, there were an randomized trial showing, it was in the 60s or in the 80s, sorry, showing that amniocentesis carried a risk of 1%. This is a recent meta-analysis in France in which 2,000 high-risk cases were randomized between cell-free DNA or invasive testing. And they found that the miscarriage rate up to 24 weeks was exactly the same, 8 cases and 8 cases. And the overall fetal loss rate up to the day of the delivery or after the delivery was 1.7% in one group and 1.7% in the other. So here we can see that it's true that there are losses after invasive testing, but most of the losses are due to the pregnancy itself rather than the procedure, the invasive procedure. Regarding primary screening, I've already spoke that in Holland, in Netherlands, they offer cell-free DNA, and in Belgium also. Let's analyze or let's review a little some points of this study of the Trident 2. When they offer, paid by the National Health Service, a screening for aneuploidies, in that society in Netherlands, only 42% choose to have a screening for aneuploidies. Sex chromosomes are not studied, and when they opt for cell-free DNA studies, then they don't have the 11-13 week scan, which is very, I mean, it's very curious. And they let women opt for basic cell-free DNA testing, test 13, 18, or 21, or genome-wide testing, so all the chromosomes. And most of the women, I have already explained, prefer to have cell-free DNA genome-wide. The working days are 6.5, and the failures at first row are low, 1.5%, and 14% of recurrent failures among the 90% repeated drugs. Finally, I would like to comment on contingent screening, and this is our experience and our protocol. Maybe it's a little bit complicated. We offer combined tests to the whole pregnant population, and if the risk is very high, we offer only invasive testing. If the risk is high, so in this group, between 1 into 10 and 1 into 250, what is generally known as high risk, then we let women choose between invasive cell-free chorionic villus sampling in the first trimester or cell-free DNA testing. And I always do this counseling, and I say you can choose between 2 tests. None of the 2 tests are perfect. Invasive testing is fantastic for detecting all the anomalies, 100% detection rate for chromosomal and also microdeletions, microduplication, but it carries a small risk of fetal loss that I quote in 0.2%. And you have the other test that is also no perfect, cannot detect 100% of cases of trisomy 21, only 98, 99%, only detects 3 anomalies, trisomies 21, 18, and 13, but it carries no risk at all to the pregnancy. So you can choose which is better for you. Usually say, doctor, you know more, you have to, but no, sorry. one is better for one thing and the other, no one of the two tests is perfect. So you have to choose which is best for you, more accuracy or safety. Finally, still, if you are in this group, between 1 in 251 and 1 in 1,100, then you are offered cell-free DNA only. And if it's less than that, then no further tests are offered. And here you can see that expanding the cell-free DNA offered to this group, to this intermediate group, it accounts for about 10% of the euprote cases, and it detects about 5% more trisomies 21 and 5% more trisomies 18, 13. So if we do a cost-effective analysis, this is also a review, a meta-analysis of all the studies on cost-effective analysis on cell-free DNA, and these are the conclusions. On the basis of modeling, it was concluded that expansion of cell-free DNA testing would be economically justifiable if offered as a contingent test to 10 to 20% of women at moderate or high risk. And the cost of cell-free DNA testing needs to fall substantially before it should be offered to all women, regardless of risk. This is the situation of the poor resources country. Also, for us in Catalonia, we cannot afford to offer cell-free DNA testing to each woman. So the budget for each person on the public health service is 1,300 euros per year, and one test is 300 or 400 euros per test. So it's not affordable to offer this to all pregnant women, but we have chosen this protocol in which we offer only 10% of the population extra. And in this way, we detect more cases that if we would use only as a secondary screen. And I would like to conclude this talk with these statements. In twin pregnancies, cell-free DNA appears to be the best method to screen for aneuploidy, although the failure rate is higher than in singletons. It isn't clear whether the fetal fraction is lower in pregnancies conceived by ART, assisted reproductive technologies. And cell-free DNA testing applied as a primary screening method has been shown to be highly effective, but is very expensive as compared to other strategies. Cell-free DNA testing applied as a secondary screening reduced the detection rate of aneuploidy because we are replacing invasive procedures by cell-free DNA testing that they don't have 100% detection rate, although also we are reducing the fetal loss rates. Cell-free DNA testing applied as a contingent screening is the most cost-effective strategy, and this has been our model. And finally, cell-free DNA testing is not recommended in ultrasound anomalies. Thank you very much. I will be happy to take questions.
Yeah. Thank you, Professor Borrell, for that absolutely delightful, if I may say, talk on NIPT. It was quite the eye-opener. We have two questions that have come in from our Facebook handle. The first question is, why is the world of commerce, which is our trade people who provide NIPT testing, still insisting that it's 99.6 and you say it is 98? How do I understand the mathematics?
Yes, it's very easy to understand. The meta-analysis now maybe have 30 papers reported on cell-free DNA, or 40 or 50. And there are some points that are very important to know. And most of those series, they are performed in second and third trimester, not in the first trimester. That is when we are applying it. More series are not consecutive cases, so they choose the cases. Case is like a case control. So you choose this case and you discard other cases. And finally, there are high-risk cases. And even the fourth point is that they don't have a complete follow-up. There is a belief that if there is a Down syndrome, I would know because they will complain, and it's very difficult that I missed a Down syndrome and it's not true. It has been shown that it's not true, because some women, they don't complain, they feel just painful for this, and they prefer not to contact to her doctor. So the point of this discrepancy is mainly due to the studies they have not complete follow-up, they are late cases, they are not consecutive cases, and they are high risk.
Thank you. We have some more questions here in the question box. One is, can SNP-based methods of NIPT be used in twins, ovum donations, and maternal malignancy?
If can be used in twins, definitely they can be used, and have shown that the results at the beginning were not so good, but nowadays, I mean, this meta-analysis is clear that the results are really good in twins. So I can think in monochorionic twins, even, I mean, it's funny because there is no any study that separate monochorionic than dichorionic, only that city from Belgium, because I assume that in monochorionic, the results that monochorionic are or monozygotic should be as good as in singleton, because even the placenta is bigger, so even it's easier. And the results may be a little bit worse in dichorionic, that are two placentas, and sometimes the fetal fraction, most of the methods of cell-free DNA, they don't check for fetal fraction separately for the two twins, if it's dichorionic. They only check for an overall fetal fraction. And sometimes the fetal fraction cannot be equal for the two. So one can be very few fetal fraction, and you can miss some cases if you don't check both fetal fractions. But this is really difficult, and there is only the Snip method that is able to differentiate between the both fetal fractions. So for twins, definitely is good. For ovudonation also is good. The Snip system is not working for ovudonation because most of the cell-free DNA, let's say 80–90%, they use a method that is called massive parallel sequencing, and they analyze the chromosome using the relative count method, that they don't differentiate maternal from fetal. They know that if the proportion of cell-free DNA coming from the fetus is 10%, and we usually have two chromosomes, so we can assume that every chromosome in the fetus is accounting for 5% of the cell-free DNA. So when we found a 5% extra, if you have a 10% fetal fraction, if you have a trisomy, you will have 3 chromosomes instead of 2. So instead of 10%, will be 15%. So this will a 5% extra. This is the way it works, cell-free DNA. So they rely on detecting 5% extra counts coming from one chromosome as compared to the counts of the other. And this is the way they detect trisomy 21. And this is the main method. There is another method which is very complicated, which is the Snip method, which is panorama, that is detecting the SNPs of the mother and the SNPs of the fetus. And this cannot be applied for ovudonation. This is the only method that cannot be applied in ovudonation, but all the others can be applied also. And there was any other situation? Twins, ovudonation?
Maternal malignancy.
Maternal malignancies.
Yeah.
Yes, in maternal malignancies, definitely. Not all maternal malignancies, they show a pattern of abnormal cell-free DNA. Most of the, I don't recall exactly, but most of the cases, let's say 90% of maternal or 80% of the maternal malignancies are hematological malignancies, so lymphomas, leukemias, also breast cancer, and also sometimes myomas. that are not malignant. So I don't know if in other kind of malignancies could be useful, but definitely I would not use cell-free DNA in maternal malignancies.
And then two connected questions. One is, what would be the sensitivity of cell-free DNA in vanishing twins? And is Snips better than MPS for this?
Yes. The sensitivity for vanishing twins, I assume that is the same, that is good, that is 98%, 99%. The point is that the screen positive rate or the false positives are higher, are like 15% or like 20%, depending on the time lapse between the death of the fetus and the point that we are taking the blood. It is, I mean, it has been described some positive, false positive cases after even 15 weeks after the demise of a fetus. So usually they say 8 weeks at least, but until 15 or 16 weeks has been described some positive result due to a vanishing twin. So in a vanishing twin, the sensitivity would be not affected, by the specificity would. And the specificity would be, so the false positive rate would be high, 15%, something like this. So maybe we can use it, knowing this, that the screen positive rate would be very high or high enough, like 15, 20%. If we assume this, at least in the other 85% of the cases, that we are not recommended to do an invasive procedure, or if it's positive for a typical trisomy, maybe we can assume that it's the vanishing twin. We can discuss this issue. Until now, it was not recommended to perform cell-free DNA in the case of a vanishing twin, but I don't see a proper or a total contraindication, provided that we know that we will have 15–20% of false positive rate, or showing the anomaly that the vanished twin is carrying. It's not properly a false positive; it's a positive of the vanished twin, but not from the remaining.
Mm-hmm. Thank you. We also have a question on the influence of technology for the detection rates. We hear new names every day. There was originally massive parallel sequencing, then Snips, and now something called rolling circle.
Yes.
What is the influence of this technology on detection rates?
Yeah. Sorry, I have not said that the Snip method is the best in case of vanishing twins, because they can differentiate each fetus, can differentiate two fetuses completely separate. That the other method, the count or the massive parallel sequencing, they use the whole amount of cell-free DNA. The third system, there is a third system still, it's not these rolling things, is applying microarrays. This is Ariosa and Harmony. Harmony is not using a massive parallel sequencing anymore, it's using microarrays. And finally, these three methods, the Snip, the massive parallel sequencing, and the microarray, are similarly effective. I think that are not big differences between them, and I don't recommend any method particularly. Maybe in vanishing twin, the Snip method would be the best. In relation to the last method that has been introduced recently, this is the Vanadis, called Vanadis, and this is not sequencing, and for this reason they claim that it's cheaper. They have a point that I don't like much, which is that they are not calculating the fetal fraction. They say that it's not needed, but definitely it's much cheaper. And their idea is, let's reduce the price of cell-free DNA to allow everyone, all women in all the countries, to have cell-free DNA testing, and reducing the price, this will be affordable by everyone. And the inconvenience would be the fetal fraction is not calculated, and it cannot be expanded to other chromosomes other than 13, 18, and 21. And still, it looks like pretty effective for these three trisomies. 98, 99%.
Thank you. We also have a question. It's a little strange to hear that question after your talk, but for the sake of the person who's asked it, and that is, if I have more than one marker on my first trimester scan, say a missing nasal bone and a thick nuchal translucency, if I choose to do NIPT and it's low risk, is further evaluation needed? So could you please give us a nice, loud, clear answer again? I know you've answered this already, but please repeat answer.
Yes, in case of increased nuchal translucency above the 99th percentile, there is a risk of microdeletions, microduplication, or also atypical anomalies. So my recommendation would be avoid cell-free DNA because it would be double price to pay for two things. But if the women prefer to start with cell-free DNA, we cannot prevent sometimes to do this, then definitely I would recommend to do an invasive procedure and a microarray.
And a related question, what is the status of the second trimester markers if I have an NIPT which is clear on my first trimester?
Yes. I mean, what I would like to have, and sometimes we don't have, is a risk. I mean, not all the cell-free DNA testing methods, they provide a figure. I like those that provide a figure, 1 in 10,000, 1 in 100,000. And then if you have a figure, you can apply the likelihood ratios in the same way that we use these ratios in the second trimester of the combined test. But definitely these risks are so low that it's almost impossible that finding a single marker, it can turn out to be high risk. If I have a low risk cell-free DNA without a figure, without a risk, then maybe definitely if it's the electasis of or hyperechogenic foci or hyperechogenic bowel, definitely this does not change much the risk of a cell-free DNA result. Only maybe a plastic nasal bone or increasing a very high nuchal translucency, then maybe I can think to offer an invasive test, and particularly in increased nuchal fall in the second trimester, maybe I can offer a panel for Noonan also. But definitely the importance of the ultrasound markers is much diminished with this extremely low risk that result from a cell-free DNA test.
Thank you. The questions are now rolling in, and I'm requesting ourselves to extend your question answer if you don't mind staying with us for a few more minutes.
Yeah, no problem.
Yes. The question here is, if I have an NT between the 95th and the 99th centile, would NIPT be a sensible idea?
Then what we do is we calculate the combined risk anyway. And then according that protocol, we offer, I mean, if the final risk is 1 into 200, they offer both things. And I tend to think that women do the right choices, and the classic role of doctors saying this is best and you have to do this is almost past. And I mean, I know that people, they don't like this. Even women, they say, no, doctor, you know as much as you that. I mean, and I say, okay, I know a lot, but because I'm saying syndromes a lot, I am completely biased. So I'm not useful to help you in choosing the right thing, because I am not in your place. I'm seeing the whole day syndromes, and I would tend to offer invasive procedures to everyone. So I'm not. So my point is, give the women a figure, put that figure on a protocol, or even if you don't have a protocol for doing, let's give that figure and let's offer everything what she thinks is better for her needs having this, if she has 1 into 100, maybe she can do cell-free DNA or invasive testing. If she has 1 into 10, probably she will choose an invasive testing. And if she has 1 into 140, probably she will choose cell-free DNA. So women, they do the right choices, and I'm completely in favor of women deciding their own protocols. Rather than sticking, I mean, in Europe, we stick on these cutoffs. We like this, the public system cannot afford for everything. And I was very convinced of this until I was 1 year in the States. And I saw that sometimes women, not sometimes, women are intelligent, and they don't have to be a stick on that strict protocols that are made by the experts, that they are not in the position of every woman. But this needs also more time to discuss. This is also, sometimes it's not easy for doctors, because sometimes for doctors, you have to do this, you have to do that. And even for us, sometimes it takes longer. You need half an hour to discuss these issues. You cannot, with 1 minute, it's impossible to discuss it. You need time, you need, and that women understand proportions, what is a risk, that sometimes not everyone understands what a risk means.
Yes, counseling can be very time consuming and very, very prolonged. Yes. So 2 quick questions before I hand over to my co-chair. And that is, if I have an isolated ARSA in my first trimester and the rest of my ultrasound is normal and my biochemistry is normal, should I consider NIPT? No by itself. I would do exactly the same. I would change the risk if I have a nuchal translucency calculated and I have an age. I can calculate the risk according to the nuchal translucency and the age, and I can modify the risk with the ARSA, that the ARSA has a likelihood ratio, let's say 8%. I multiply the risk by 8 and I give a final figure. Or I mean, I try to transform all the findings to a figure and discuss that figure with the women, rather than saying ARSA, you have to do this and other. So have a figure, and calculating a risk. I have a combined test, I modify the risk of the combined test. I have just the age, I modify the risk of the maternal age. And modifying a risk and having a final number, just the final number, and discussing what to do with that final number. Wonderful. And can NIPT detect translocation Down syndrome and Mosaic Down syndromes?
The answer is to the first question is yes. I mean, they detect translocation in the same way that they detect free trisomies. I mean, in the same way, because the extra genome material is the same. And mosaicism, we don't know much if they detect mosaicism. I assume that high-level mosaicism, let's say 78%, 80% is detected, and low-level mosaicism maybe can be missed, so maybe less than 20%. Which I assume that they are missed, less than 20%, and about 80% they are always detected.
Thank you so much for your patience in answering these questions. But we have one question from my co-chair. Over to you, Dr. Thielen Praveen, for your question.
Thank you. Professor, what do you say about the selective reductions that we practice in an abnormal fetus, which we have done, and then later on you find that there is one soft marker in the existing twins? Do you advise NIPT, and if so, how do we go about it?
Yes, this is a difficult question. We have as compared to the vanishing twin in a selective reduction, we probably that fetus that has been reduced is not affected by a chromosomal anomaly that usually in a vanishing twin it is affected. But at least I would respect 8 weeks after selective reduction. So I would not recommend cell-free DNA before 8 weeks after the reduction. And ideally, I should wait until 15 weeks. And so you between 8 and 15, it's an intermediate situation. After after 16 weeks, I think is pretty safe.
Okay.
Or pretty accurate.
Thank you. Wonderful, Professor Antoni Borrell. It was a wonderful lecture, and it was really, as Ashok said, an eye-opener. And a lot of aspects have been very concisely and precisely put forward. And thanks for that lecture, and thanks for being with us, answering all our doubts and queries. Thank you very much.
I'm very happy to participate in this webinar. Thank you for the opportunity to join to share my data with you.
Thank you.
Thank you indeed. We move on to the rest of our program for tonight. And I hand over to Dr. Thilan Praveen to introduce our next speaker.
Welcome to this webinar, second webinar on Executive Committee webinar. And today we have wonderful topics. Both the topics are really extremely useful in our day-to-day practice. The first one being what genetic tests to be asked. I think every one of us who is practicing fetal medicine or who is practicing ultrasound for the fetus do come across this sort of an enigma in our day-to-day practice. And here we have Dr. Shagun Agarwal. She's also from my town, that is Hyderabad, and she's an additional professor in the Department of Medical Genetics at Nizam's Institute of Medical Sciences. She's also a scientist in the CDFD, that is the Center for DNA and Fingerprint and Diagnosis. And she has been she's a gynecologist basically, and then she did her DM in medical genetics. And she has innumerable number of peer-reviewed or indexed articles as well as non-indexed articles. And she has contributed 7 chapters in the test book. And she's also an associate editor of genetics update of the next generation clinicians. So with this, I hand over to Dr. Shagun to take us through this very important aspect of our day-to-day practice, that is choosing the correct genetic test. Over to you, Shagun.
Thank you, sir, for that wonderful introduction. I hope my screen is visible.
I think you need to share.
Please, 1 second. So thank you for that wonderful introduction, sir. What I'm going to talk about is basically a kind of the practical approach to how to choose a genetic test when we are faced with a situation where there is an abnormal ultrasound finding. So now with advances in genomic technology, we literally have so many tests which are available at our fingertips. And these tests actually enable us to look at the fetal DNA in such intricate detail, which was like kind of unimaginable with a simple karyotype a few years back. So, but now with this, this ability to look into this DNA, actually, I mean, it should simplify things for us. Probably we were hoping that, it will clear up so many gray areas, but then that's not always the case. So often we are now having a situation where we are baffled by the array of tests available to us, and we don't really know which test to offer in a particular situation. So, and on top of that, in a prenatal scenario, we have the time crunch. We have just one opportunity of taking the fetal sample. And also the phenotype of the fetus is not really completely apparent as of now. So which again raises problems at the time of interpretation of the report. So there are so many challenges in such scenarios. So what I hope to achieve through this talk is probably we can kind of come to some kind of an algorithmic approach as to how we should go about whenever we have these abnormal scan findings. So we all know that these are probably the 3 main categories of abnormal scan findings. We could have soft markers, isolated or multiple, which are mostly associated with cytogenetic abnormalities. Structural abnormalities, again, isolated or multiple, these actually could be associated with cytogenetic abnormalities, or could even be associated with single gene disorders, and around 10 to 14% of these structural abnormalities, and even higher probably now as the current data shows, are probably syndromic. And then finally, we could have miscellaneous abnormalities of growth, liquor or placenta, which often are not genetic, but in certain instances could be. So what next? So when we have an abnormal scan, so usually one of the factor which goes into decision making and which we counsel the patient about is the actual prognosis of the particular finding. What is its course going to be in the postnatal period? What are the treatment modalities possible? So this kind of gives a picture to the patient regarding how severe the particular finding per se is. But the other very important aspect is to realize whether this particular abnormality which we are seeing on scan, is it part of a genetic condition? Because this really determines other associated things which could happen to the baby once it's born. So if there is a genetic condition, there would be associated comorbidities in most cases, and the most problematic of that is intellectual disability. So both these aspects are really important to kind of communicate to the patient, and so that we can enable a appropriate decision making. So when we say genetic disorder, so as Dr. Tony also showed in his talk, so we are basically referring to 3 different categories of disorder. One are the chromosomal abnormalities. So these are the problems in the number or the structure of chromosomes, and these can be easily picked up by doing a simple karyotype. So this is what we were doing all these years. So a karyotype, or in case there is a problem in the timing because of advanced age, we can do rapid aneuploidy testing using FISH or QFPCR or MLPA. Then we have the second group of genetic conditions. These are the microdeletion syndromes, or even the corresponding microduplication syndromes, where there are very small losses or gains in the chromosomes which cannot be seen in the karyotype. So in such cases, we would need to do some advanced molecular cytogenetic tests. Example of that being FISH again, and also we have other tests like MLP, and now we have chromosomal microarray, by which we can detect these very small changes in the chromosomes. And finally, we have the changes occurring at the level of individual genes, which can be at the just a single base chain. So these cause the single gene disorders, and these will not be picked up using a microarray also. And here we need to actually sequence the DNA. And this sequencing traditionally was the Sanger sequencing, but now we have the next generation sequencing also available to us. So these are the 3 main categories of genetic diseases we need to keep in mind. So if we look at congenital malformations at birth, these are found in around 2 to 3% of live borns, and these could again be isolated or syndromic. So a genetic etiology is found in around 15 to 35% of congenital malformations. These could be chromosomal or single gene disorders, both almost equal in kind of prevalence. And we could really also have microdeletion, microduplication syndromes, and the malformation could be part of that. So all these 3 kind of genetic disorders could be there in the setting of a malformation. So an example of that, if we take common congenital heart disease, so this could be part of a chromosomal disorder like Down syndrome. So 30 to 40% of prenatally detected congenital cardiac disease are actually because of Down syndrome, or some other chromosomal abnormalities also. And then we have Digeorge syndrome, which is a microdeletion, and this is found in 5 to 20% of conotruncal cardiac defects. And we could even have a single gene disorder. So a baby with cardiac defect could have a single gene disorder like Noonan syndrome. So this is seen in 2 to 20% cases with increased NT with or without a cardiac defect. So the important thing here is why we should not miss these genetic conditions is that, as I said before also, these are associated with intellectual disability and other systemic comorbidities in the postnatal period. So similar to cardiac defect, various ultrasound abnormalities, we all know that they are associated with these different degrees of aneuploidy risk, but then we also need to remember that they could also be part of a copy number abnormalities, a microdeletion or a microduplication syndrome, and this figure is really high, especially for Holoprosen-Kefli and Danny-Walker malformations. But in addition to this, we could also have a single gene disorder, and these single gene disorders could also be presenting with these various ultrasound abnormalities. And here the ones which are actually are really the kind of ultrasound abnormalities having very high prevalence of single gene disorders are hydrops fetalis, and also certain CNS malformations, fetal akinesia, and skeletal dysplasias. So all these categories, 3 categories of genetic disorders are possible, and then they can have other comorbidities postnatally. Hence, these were, so in the era of karyotype, when we did not really have array or NGS available to us in the clinic, so at that particular point of time, when we used to offer a prenatal to a patient for ultrasound abnormality and the karyotype was normal, we still had to counsel the patient for a residual risk of intellectual disability and other problems, because we could not really test for the microdeletion, microduplication syndromes or the single gene disorders at that particular time. But now this is possible and this should be done. And also the other important fact is that for the single gene disorder, even the next pregnancy is at risk, because these can have a high recurrence risk. So a comprehensive genetic testing is actually what is needed, and this is often a balance. So we have so many tests, so the balance of what to choose, how to choose, is actually a kind of a game between cost, time, and the yield of the test for a particular abnormality. So I'll just take you through some cases to kind of highlight which kind of tests could be useful for certain specific scenarios. And these cases are actually also in a kind of a time-based chronological order. So the earliest case is in the era when we did not have array available, and the latest case is the one which we have just recently seen when we have all technology available at our disposal. So this is the first case where we had a non-consanguineous couple, and their first baby was affected with autism, and they had come to us at 18 weeks with a referral diagnosis of ultrasound showing tetralogy of Fallot, and an amniocentesis revealed a normal karyotype. But we all know that tetralogy of Fallot, it is basically a conotruncal defect. It shows a high association with Dye-George syndrome. So that's why in this case we did an MLPA. So MLPA is another test, just like it's a molecular cytogenetic test like FISH. So this can also detect the various microdeletion syndromes. So this indeed showed that this fetus was affected with Dye-George syndrome. And in fact, when we went back and we checked the whole family, because Dye-George can have a very variable expressivity, so we should always check the family members. So we found that in fact the mother, who was completely asymptomatic and healthy, also had this microdeletion. The previous child who had autism also had the same microdeletion. And now with this information, the recurrence risk for this couple jumped to 50%, as compared to for a sporadic cardiac defect, it would have been around an empirical risk of around 5%. So the kind of message from this case is that whenever we have a cardiac defect antenatally, especially a conotruncal defect, besides the karyotype, we should also think of 22q deletion. And now in the era of microarray, of course, we should do microarray in this particular scenario, because besides Dye-George, there could be other microdeletion, microduplication syndromes also, which could also present in a similar fashion. So then moving on to the second case. So this was in fact a case with only soft markers and no structural anomaly. Again, a non-consanguineous couple, previous healthy child. So this baby had pilectasis and mild ventriculomegaly. No malformation, normal anthropometry, nothing else on the scan. And this was a karyotype of the baby. So the karyotype was reported as normal, but whenever you see this kind of karyotype, just remember this is not the really best karyotype. These are like really tiny blurred chromosomes, so we could miss certain things here, and that's what was there actually in this case. So when a microarray was done in this particular case, so in the there were like 4 duplications which are reported. Again, often in microarray reports, you may find more than one copy number defects reported, but then 2 of them were benign, one was of uncertain significance, but there was this one huge duplication which was likely pathogenic, and this was on the 8th chromosome. And this region, duplicated region, contains around 190 genes. It's not reported in normal people. Already it has regions which are known to present with phenotypes of intellectual disability and all. And most importantly, it was missed on karyotype. So in this particular case, although it was just soft markers, but again, doing the microarray really helped in closing the kind of the situation for this family, and they were able to take a decision for termination. So if we look at the data on prenatal microarray, we find that in case of abnormal ultrasound findings, in 6 to 10% cases, you would have an abnormal array. And these would be findings which abnormalities which will be missed on karyotype. And even with normal scan findings, you could have copy number defects coming up on a microarray. And there are different figures for different anomalies. If you have multiple anomalies, then the array's yield goes up to approximately 9 to 10%, and even with an increased NT of more than 3.5 mm, in 3% cases, you would find an abnormality missed on karyotype. So at present, microarray is the recommended cytogenetic test, which should be offered to all cases where there is an abnormal ultrasound or even fetal demise or stillbirth. But if you have a normal scan or you are doing prenatal for some other indication, then this should be given as an option to the patient, because in such cases also there could be copy number abnormalities which are not picked up on routine karyotype. So in the arrays also now, you would have so many companies coming to you, and you have these different types of arrays being offered. So how to choose between them? So we have usually we can divide them into the low resolution array and the high resolution arrays. So the low resolution are the ones which look for aneuploidies, and which look for common well-defined microdeletion, microduplication syndromes, and is usually able to give us a clear-cut yes or no report. Whereas a high-resolution array would look much deeper. So it could even look for other previously unknown copy number abnormalities. So its resolution is really high, but then once the resolution increases, what happens is that you could end up with a copy number variation of uncertain significance, and this can cause problems in counseling and decision making. So usually it's better to do a low resolution array if you have a normal scan or just some soft markers, and these are usually some of the common ones available in the market. But if you have abnormal ultrasound findings, significant structural abnormalities, it is better to do a high resolution array, because you could be looking at some new condition, and this would be missed on a low resolution array. So now moving on to the situations where you could have a single gene disorder. So we saw the situation where there was cytogenetic abnormality, and we came to the conclusion that a microarray is the test of choice. Now let's look at the new frontier, which has opened up because of the availability of next generation sequencing. So till now we were able to look at all the cytogenetic abnormalities, that is the chromosomal abnormalities, but we were not able to diagnose a single gene disorder in a fetus when there was an abnormal scan findings. Maybe in certain cases, like where you had typical findings like Meckel-Gruber syndrome, there you could make a diagnosis, or some specific skeletal dysplasia like thanatophoric dysplasia. But in most cases, you could not really say that a baby is having a single gene disorder, and you could not do any test for that. But now NGS makes this possible. So this particular case is actually the first case where we had done a fetal exome, and it was probably one of the first few cases in the world at that particular point of time. So this was a third-degree consanguineous couple. Their previous baby had corpus callosum agenesis, developmental delay, hearing and vision problems, and they had come to us in pregnancy at 17 weeks gestation. So the previous child's workup was incomplete. So we did not really know the diagnosis of that child, and the child was deceased. And now in the present pregnancy, as early as 17 weeks, we could appreciate some dangling choroid, and the fetal karyotype was normal, and an MRI was done, and the MRI indeed confirmed that this baby also had agenesis of corpus callosum, but there was no other finding. So we all know that an isolated corpus callosum agenesis has a good prognosis. Around 70% cases would be actually normal. But in this family, because there is already history of a sibling affected similarly, and that sibling had a poor outcome. So here we can already, at this point itself, even we don't do any testing per se, but we can counsel them that this looks like a recurrence, this looks like an autosomal recessive condition, and the prognosis is likely to be poor. So that's what was done, and the family terminated the pregnancy. On autopsy, on gross examination, there was nothing else except for corpus callosum agenesis, but on histopathology, there were abnormal cortical layering, which was appreciated. So here, when we did a whole exome on the stored amniocyte DNA, so again, important always is to store the DNA whenever you have done sampling, because you can always go back, use that DNA for testing. So here we use that DNA, and we found that this baby had a homozygous pathogenic mutation in this particular gene, and this was actually a case of Vicky syndrome, and this is actually a very rare condition. And the previous child also, when we reviewed, we found that the diagnosis fitted with that clinical picture also. And then we were able to give them a recurrence risk for next pregnancy and offer them prenatal testing, which luckily revealed unaffected fetus. So just to reiterate, isolated corpus callosum agenesis usually has a normal postnatal outcome, but could be part of a genetic syndrome. And here, because of a positive family history, it was kind of easy to say that this is probably a genetic condition and therefore a poor outcome. So that particular case, we had done an exome later on, but now that exome is being increasingly used and we are already having literature reports, a lot of information available that it can be used in the prenatal period. So now we have, in selective cases, we are offering it in the prenatal scenario also. And this is a particular case, which is a very recent case. So a consanguineous couple where the first baby had been terminated because of short limbs polyhydramnios at 23 weeks. And now at 24 weeks, at this pregnancy also, she was referred with skeletal abnormalities. When we did a scan, we found that she indeed had shortening of long bones, more upper limb and more in the middle segments. So besides that, all the other ratios, thoracic circumference was normal. So basically we had moderately short bones, which were normal in contour and density, predominant mesomelia, more in the upper limbs, normal thorax dimensions and ratios. So this was a non-lethal skeletal dysplasia. And there were also other interesting findings in the form of dysmorphology. So there was some frontal bossing, mid-face hypoplasia, mild hypertelorism, and some minor digital abnormalities, and also vertebral segmentation defect. So putting all this together, actually the diagnosis which is suspected for this fetus was a genetic condition called as Robinos Syndrome, because this condition really presents with these spectrum of findings. So on basis of this, we counsel the family, and because this Robinos syndrome is a non-lethal skeletal dysplasia, and also after birth, most of these individuals will have short limbs, but their degree of short stature is in the mild range, and they don't mostly have intellectual disability or other systemic problems. So it's not really a very bad prognosis condition. So, and also this pregnancy was little advanced, so they continued the pregnancy after counseling. And we did an amniocentesis at that particular point. Karyotype was normal, but whole exome sequencing on the fetal DNA confirmed our diagnosis. So there was a variant in this gene which is known to cause Robinos syndrome, and this kind of helped in further reassurance of the family. The pregnancy was continued, and because this was a situation where the prognosis of the baby was likely to be favorable, so even a cesarean section could be done for a fetal indication. And the baby had an uneventful neonatal course, was brought to us on neonatal day 9, when we were able to see the classical facial dysmorphism and the short limbs, which is kind of typical of Robinos syndrome, along with some digital findings and the X-ray findings. So this particular case kind of like, although the amniocentesis here was done in late pregnancy, so many of often there are confusions whether we should do invasive testing in later gestation after 20 weeks. But we need to remember that we are not doing invasive testing to terminate a baby. We are trying to give a diagnosis to the family. Giving a diagnosis to the family is not only for the purpose of doing termination, it is also for the purpose of managing the pregnancy, for preparing psychologically and for the subsequent postnatal events, and also for appropriate intrapartum and neonatal management. So that's how this case actually it kind of optimized the management for this particular family. So so if you review the literature on fetal exome sequencing, so this was first done in 2014. This was the first report by Kars et al. And they found that in 30 babies where they did whole exome sequencing, 10% of them had a single gene disorder. And at present, if we look at literature, there are at least 16 large studies and various case reports. And overall, they show that whenever we have fetal structural abnormalities, either detected prenatally or at the time of autopsy, at least 20 to 30% of such fetuses have a single gene disorder. So just look at this figure. This figure is much more than the 6 to 10% figure of chromosomal microarray yield. So single gene disorders are much more common than microdeletion, microduplication syndromes when we are having a situation of a structural abnormality in a fetus. So, and the other important thing about single gene disorders is that they have a high recurrence risk, which is not really there for chromosomal abnormalities. So this recurrence risk can be 25% for autosomal recessive condition and 50% for dominant condition when one of the parent is affected. And in fact, now we have guidelines by SFM and ISPD, which was published in 2018, and even the American College of Medical Genetics have published recently guidelines regarding the use of exome sequencing in the prenatal setting. So in our own experience, we have at present done around 72 fetal exomes, and out of which we have got a diagnostic yield of around 46%. Most of our fetuses have autosomal recessive condition, which is not surprising because from where I work, majority of our patients are actually consanguineously married. And in fact, otherwise also our Indian population, there is a lot of endogamy. So we really have more prevalence of autosomal recessive condition. And in fact, in our work, we also found various other interesting findings, which we have recently published last year. So what is the utility of doing exome sequencing in the clinical practice? So it's quite similar to like what I have been, I have been saying previously, that whenever it basically gives us an answer whether there is a genetic syndrome in the fetus. So this would kind of help the family in deciding whether they want to continue or abort that particular pregnancy, or in case of a late diagnosis, it can help in planning the treatment. And also it helps in recurrence risk counseling and providing an early definitive prenatal testing or other reproductive options to the couple for subsequent conceptions. But then there are certain problems which always come. So this is a little, it's kind of a new technique as far as use in prenatal period is concerned. So there are some challenges which still remain, and this is still evolving. So usually prenatally, we won't really have a complete phenotypic information. So it becomes challenging in the lab often to give you a concrete report. And then there is also the problem of variant of uncertain significance. So you may get a variant which matches your fetal phenotype, but the lab is not sure whether it is pathogenic or not. So again, this kind of leaves us nowhere, and we are again in a gray area when we can't say whether the baby has a genetic condition or not. And then there could be certain other problems like incidental findings. You could find some disease in the parent through the fetal's exome, and that causes issues. And then there are practical problems. So practical problems of turnaround time. When do we offer the exome? Like, do we wait for the karyotype report to come and then do the exome? Then there's often not enough time to do all in this serial-wise kind of stepwise manner. And then because of all these challenges, there are complex genetic counseling issues. So we don't have enough manpower for this, and cost, of course, the additional cost for the patient is a big concern. So due to this, the society guidelines by ISPD, SFM have actually said that at present NGS, if it is used in prenatal period, it should be done in specific situation and in consultation with a geneticist, and always with a pre and post test counseling. So again, there are some other things in the practice which comes. So various labs have these different kind of tests which they offer. So there are some gene panels, like you have Noonan panel or cystic kidney disease panel, or you have the focused exome, also called as the clinical exome, where only the clinically relevant genes are kind of studied, or you have the whole exome and the whole genome. So usually a gene panel would kind of give you too little information, and whereas whole exome and whole genome would kind of give you too much information, which would become difficult to interpret. So the ideal thing or the right fit is the focused exome when we are doing a prenatal NGS. So this is important to remember. We should not get swayed by the companies, and we should know that this is usually the best test to offer. So again, when should we do it? With or after the cytogenetic testing report? So should we do an array first? Should we do an exome first? So often this kind of decision would depend on a lot of things. What is the gestation of the patient, and also what kind of scan findings and clinical structure we are looking at. So we could kind of divide this or kind of take this decision in this fashion. So first we look at the fetus. So what kind of abnormality are we looking at? Suppose you have duodenal atresia. So duodenal atresia usually is associated with cytogenetic abnormality, Down syndrome being the most common. So there you would offer a karyotype or a microarray rather than offering an exome to the patient as a first go. Whereas if you're looking at echogenic cystic kidneys, then in that situation, it's more likely to be a single gene disorder. So better do a exome right away rather than waiting for a cytogenetic report to come in. Then you could have an omphalocele growth abnormalities where you should be thinking of Beckwith-Wiedemann syndrome. So there you would do a different test, which is called as an MSMLPA. So really the type of abnormality also determines what test we should be offering first. And then whether it's a single abnormality, multiple abnormality. So multiple abnormalities, usually if with a structural multiple malformations, so most of the time the pregnancy would be terminated. So there is no hurry to do everything together. You could actually take a sample, first do a karyotype, bank the DNA, and then depending on the phenotype of the baby after delivery, you can plan subsequent microarray or exome sequencing. But if it's a single malformation and there's no clue as whether it could be cytogenetic abnormality or it could be a single gene disorder, in that situation, you could offer together exome sequencing as well as microarray to kind of save the time of the patient. So then also another important thing is what is the pattern of the abnormality. So if you have multiple malformations, are they fitting into a specific condition? So suppose I see holoprosencephaly, polydactyly, multicystic dysplastic kidney, I'll think of trisomy 13. I would not go and do an exome in that case. And whereas if I'm looking at encephalocele with polydactyly with multicystic kidneys, then I'm thinking of Meckel-Gruber, which is a single gene condition, and I will be doing an exome there. So look at the pattern and see what it fits into, and that can also guide us into which tests to be done. And then other thing is to look at the mother. So again, maternal age, we know advanced age. So it is more associated with aneuploidy. There could be maternal diseases having a teratogenic effect like diabetes, or there could be a maternal genetic disease. So you could have a mother who's slightly short and who actually has Noonan syndrome, and it has got undiagnosed. And now you're seeing a fetus with an increased NT on scan. And this increased NT is due to Noonan syndrome transmitted from the mother. So take a close look at the mother and also, of course, the father also. And then they also take history of teratogenic exposure or other pregnancy complications, which could explain the scan findings. And then finally, the family. So this is really important. So if you have consanguinity, again, your suspicion of a single gene disorder should be high. So consanguinity increases the risk of autosomal recessive condition. So you have a malformation on scan, the family is consanguineous, probably it is more likely to be an autosomal recessive condition rather than a chromosomal abnormality. So if there is a problem of cost, so you can just do a karyotype and exome sequencing instead of doing a microarray. So then if you have a history of a similarly affected sibling or other family member, again, here also we would be thinking in terms of a single gene disorder rather than thinking of a chromosomal abnormality. So again, this can help us in deciding what test to offer. So most of the time by kind of following these basic things, we can kind of save time and also money for the patient, but many times we cannot, and sometimes always, life throws surprises all the time. So in fact, this is just one kind of a teaser case. This was a primea gravida at 27 weeks, and scan had showed bilateral echogenic bulky kidneys with the poor CMD and irregular contour. And there was also polyhydramnios, normal anthropometry, and some subtle facial dysmorphism like this bulbous nasal tip. So looking at all these things, what we were thinking is that could it be an aneuploidy? Could it be Beckwith-Wiedemann syndrome? The overgrowth is still evolving, or maybe it is some renal monogenic disease, especially this one HNF1B variants, which can actually present with echogenic kidneys and polyhydramnios. So that's what we were thinking. So we did not even think of doing a microarray. These are the tests which we did. So but what came to our surprise was that exome sequencing revealed a micro microdeletion in this baby, so which could have been picked up had we done a microarray. So, but then interesting is that this is the region which contains this HNF1B gene, so which we were thinking of originally. So that is kind of one interesting thing. So you may not always be able to order the correct test. That's also there. But then other important thing is that NGS now also has the ability to detect copy number variation. So, but it's not the ideal test yet. To do that, ideally still chromosomal microarray, but the technology is evolving, and soon we are hoping that whole genome sequencing would become a single test which could actually pick up both the single gene disorders and all the chromosomal disorders. So all these kind of problems of choosing the test would hopefully end one day. So I think with this I would end.
Yeah. Thank you, Dr. Shagun. It was wonderful, and you really took us through the various aspects of genetic evaluation, right from the karyotyping to chromosomal microarray, as well as the clinical exome sequencing, whole exome sequencing, and the next generation sequencing. I think we will take the questions at the end because we are already running short of time, and I think we will invite Dr. Ratna Puri to take over. And she will be talking to us on another very interesting aspect, that is the fetal autopsy alternatives. And as you all know, Dr. Ratnapuri is our past president, and she's extremely dynamic, and she has been putting in a lot of inputs, genetic inputs, where we have been able to conduct certain genetic syndrome, seminars or the webinars for the past 10 episodes, and we have almost covered all the aspects of various systems. And we all know she is the professor and chairperson of Institute of Medical Genetics, Sir Gangaram Hospital, New Delhi. She's basically a pediatrician, but did her in DM medical genetics. And she's the IC Verma Outstanding Research awardee, and at the same time Dharmavira Award of Excellence. And she has more than 130 publications to her credit. Dr. Ratnapuri, can you please share your screen?
Thank you very much for a very kind introduction. And it's a pleasure to be here. And Shagun has asked me to speak on fetal autopsy and its alternatives. What are the practical aspects and the futuristic dreams? I'm just trying to get it onto full screen mode. So is my screen visible, Dr. Praveen?
Yeah, okay. Yeah, and you're audible and your pointer is also there.
Thank you. So what is the need of a fetal autopsy? We do know that 3 to 5% of the pregnancies are complicated by fetal malformations. And in our country, cumulative, it accounts for about 20 to 25% of the perinatal deaths. And now with great ultrasound machines and even greater ultrasonologists, we have really early detection of fetal structural anomalies, very often a large percentage in your 12-week scan. So it's very important that we have timely confirmation of the etiology, because if there are major malformations, the pregnancies are discontinued. And if you haven't thought as to why it's happened, it's a challenge to counsel these families appropriately, to guide them for informed reproductive decisions. And then we also want to prevent bad obstetric outcomes, like we see in this case, where they have lost 4 pregnancies before really somebody thought, let's have a look at what's happening and then make sure that the next pregnancy is not similarly affected. So what are the common indications for fetal autopsy? Either they are malformations, it could be major isolated malformations or multiple malformations, intrauterine fetal death, intrauterine growth restriction, non-immune hydrops fetalis, or any abnormalities of fluid, and more commonly oligohydramnios. And while we counsel families for autopsy, there is always a recurring question which the couples do ask us. And that is, what is the likelihood that when you do the autopsy, that you would be able to identify the cause? And this was the question which made us look into our data. And this was about 5 years ago, 5 to 6 years ago, we published this paper on about 1,000 fetal autopsies. and what were the different indications and the diagnostic yields in individual indications to guide families to answer that question. Now, what are the roles and challenges of an autopsy? I think the most important role of an autopsy is the need of a detailed phenotype for the fetus, because it does complement the ultrasound findings. There is enough data and literature to tell us that with the additional data of an external and internal examination of the fetus, histology, and radiographs, we do get additional data that was not identified in the ultrasound. And today's era, as you have seen in the presentation by Dr. Shagun, this is really imperative because we are doing a lot of genomic-based tests, whether they are chromosomal for chromosomal disorders or for single gene disorders. We also now identify what is referred to as blended phenotype. In fact, in one of the work that has just been completed in my department, where we took 80 families, not 60, 80 families, and did a trio whole exome sequencing in fetuses who did not have a chromosomal abnormality. That means we had excluded that, but had malformations which suggested a genetic origin. We found 5-6 families where there were blended phenotypes. That means there were 2 genetic disorders in the fetus, and this has major implications for counseling. So we have 2 different genes that are causing disorders, and the phenotype is a combination of the 2 disorders which are present as a result of mutations in those genes. And then there are various disorders, and an example that really came to my mind when I was making this presentation is arthrogryposis multiplex congenita, that can have a variable prognosis and outcomes. It could have a very severe and a lethal phenotype, and other phenotypes like distal arthrogryposis or amyoplasia can be really mild. And then also in this genomic era, when we are doing a reanalysis of our genomic data, because maybe a year ago we did not find any anomaly, but I'm convinced in my mind that yes, that is a genetic disorder. Or we are further doing additional higher advanced tests like genome sequencing. If I haven't done an autopsy and I don't have good phenotype data, what am I going to reanalyze for? What am I going to reanalyze with? And that becomes imperative in this era. So I'm just going to go through some cases and highlight some of the really key points that are relevant in these points that I've just alluded to. So this was a lady, 33 years old. 2 pregnancies had been discontinued, and she came again in the 4th pregnancy, where that's all the notes said. Swelling in the back of the head, and the head was not properly formed. Was it an encephalocele? Was it an anencephaly? There were no further post-abortal notes detailing the phenotype once the baby was expelled. So we really didn't know what we were dealing with. And in this pregnancy, the lady had received periconceptional folic acid. But here was the typical phenotype that was associated with occipital encephalocele, postaxial polydactyly, and large echogenic kidneys. So you know that in this phenotype, which was there in the 2nd trimester scan, we could be dealing with Meckel-Gruber syndrome because you had all the features there. However, in early terminations, you may not see the large echogenic kidneys at times because it's just a skin tag. There is no bone in the postaxial polydactyly that is seen. You don't pick up the polydactyly in the scan. But when you do the autopsy, you pick these things up. And even though you know that this is Meckel-Gruber syndrome, we have a large number of genes that can be associated with the phenotype. And therefore, you would do now, as Dr. Shagun said, the focused, the focused exome sequencing test, or the focused number of genes that look at the phenotype and other differentials that could be associated with this. And these are all disorders that have a 25% risk of recurrence. And the family then has options once you've identified the genetic defect, whether they want to do a normal pregnancy and a prenatal testing, or they want to go in for pre-implantation genetic testing and testing for the mutations in the embryos. Now, this is another case where 2 pregnancies were affected similarly, and there was very, very good phenotype data with agenesis of the corpus callosum, hydrocephalus, a Dandy-Walker malformation. And there was also arthrogryposis on external examination of the baby, and there were large echogenic kidneys. Now, we thought of n number of diagnoses. The array was normal. But when we actually did the exome sequencing, we identified a metabolic disorder. This is a congenital disorder of glycosylation with hardly any reports on the antenatal phenotype. In fact, this was the first report of the fetal presentation of this disorder, and there were really only 3 cases described in literature, 2 being postnatal, all being postnatal presentations. So therefore, you need very stringent phenotypic correlation to be able to understand, to be able to correlate the genotype data that you get. And you can see here that this is also an autosomal recessive disorder with a 25% risk of recurrence. And therefore, it's imperative that you do a good autopsy, have all this data, do the radiographs to be able to guide you further. There are some situations like what I've just put here, where you see the fetus, like we see a child postnatally, and make what we call a Gestalt diagnosis, because you've seen them once, all the babies, and now even the fetuses look similar. So, this is a Cornelia de Lange, this is a Seckel syndrome, this is a Rubinstein-Davy syndrome. So when we are doing an autopsy, we use the soft dysmorphic features, the typical constellation of anomalies as very, very key diagnostic tools. And through a very systematic approach, make a clinical genetic diagnosis. If you just send off, testing without really having all these key features, it's very, very difficult to correlate at times what we get in the reports. Now, in this situation, this is one case which is really very interesting, where it was a consanguineous couple and there was bilateral renal agenesis. And obviously no liquor, etc. There was mild ventriculomegaly, but nothing much to talk home about. There were contractures, but possibly because of the oligohydramnias. The microarray was normal, and the whole exome sequencing did not identify any pathology. And the reason for that was, now you see this whole exome sequencing had been sent off prenatally before the fetus had been examined. Now, because renal agenesis, we think that it is a monogenic disorder, or at times can also be associated with microarray analysis. But when we saw the fetus, we realized that there was renal agenesis, the ureters were not seen, the uterus was absent. So this was actually a mere Rokitansky syndrome, which is not because of a mutation in a gene. It's a sporadic occurrence. And so here the risk of recurrence is also negligible. And this is what I was talking about, a dual diagnosis. 2 pregnancies had been discontinued for large cystic echogenic kidneys. And they were typically, you had variable size cysts which are present in all parts of the nephron, and these were the kidneys. And when we did the mutation testing, we identified mutations in both the PKD1 and the PKD2 gene. And when we went into the details, of course, there was a family history of polycystic kidney disease in the side of the mother. But on the other side, where the other gene was inherited from the father was asymptomatic, though his father had died of chronic kidney disease and had not been tested. Now, chronic renal disease is not uncommon, and most of the times it's not genetic. So though here we had suspected that this could be autosomal dominant kidney disease, we had not suspected it on the other side. So these are the mutations in both the 2 genes, the PKD1 and the PKD2 gene. So therefore, this is what I referred to as a blended phenotype. It was the interaction of both these 2 genes which had caused a very severe fetal phenotype. Otherwise, most of autosomal dominant, I think I forgot to tell everybody that these 2 genes cause autosomal dominant polycystic kidney disease. which is a later onset presentation, where they would present, in adulthood with hypertension, etc. So here, because of co-inheritance of both the genes from both the sides, it caused very severe fetal disease. And because both partners were carrier, the risk of recurrence becomes very high. So what is the way forward? The way forward really is, it's something which is well established. The need of a systematic approach in fetal anomalies, evaluation of a genetic etiology is not just by ordering a test, because you get a high probability of extremely inconclusive findings. Therefore, you need a dysmorphology evaluation, you need radiological studies, histopathology, followed by a genetic testing in a very systematic manner. Now, we know that arthrogryposis multiplex congenita is etiologically heterogeneous. It may be non-genetic, or it may be of genetic origin. And even within the genetic origin, it just goes from, the brain to the nerve, to the muscle, to the connective tissue, and to the joint. Now, in this family, so we do have antenatal detection. It can be detected as early as the first trimester, which is why I'm trying to say that these pregnancies that are terminated so early really need to be examined in detail. We also know that an earlier gestation correlates with a greater severity, whereas others can be identified usually in the second and the third trimester. And when we do an autopsy here, we like to do a detailed evaluation of the brain, the spinal cord, the nerve, the muscle. Every part is taken because it could be a defect in any part. And there is a host of testing options because there are more than 400 genetic disorders that can cause arthrogryposis. So we go in a typical pattern of first doing a microarray analysis and then doing the genome testing. And we get about a 50 to 60%. We don't even know the reasons of all the causes that caused arthrogryposis. Now, if you see this child, this was a lady who had an NIPT done because of advanced age. It identified a trisomy 14. We did, and there was a bilateral clubfoot, which can also be isolated and operated. It may not be a part of a genetic disorder. So at 16 weeks, an amniocentesis was performed in view of this. We evaluated for a trisomy 14. We also wanted to look at the UPD because there is a genetic syndrome caused by UPD14, but the report was normal. And then at the 19-week scan, there were additionally clenched hands. So now you knew that you were dealing with two sets of joint contractures. So this was arthrogryposis multiplex congenita. And then we also looked at the placenta for confined placental mosaicism, which was absent. Now, when we first ordered the test for this fetus, it came back as a normal report. But because we had done the autopsy, we had found subtle dysmorphism, and we were fairly certain, we re-examined the data with specific phenotypic terms and identified a mutation in a gene which can cause an X-linked recessive, but our fetus was female. So it was less likely. It then caused what is referred to as, this Weicker-Wolff syndrome. I don't think the name is important, but what is important to understand that this phenotype is like a dominant phenotype on the with a gene on the X chromosome, which is why it's referred to as female restricted. And because we had done a trio exome sequencing, and you can see here is the fetal sample with the change or the mutation, but the parent sample is normal. So this was de novo. It's identified, it manifests only in females. And because it's a de novo mutation, the risk of recurrence for this family is negligible. So you can only go to this extent if you have done the entire workup for the family. And then finally, to conclude my talk, coming to the newer aspects of fetal autopsy is what we refer to as virtual autopsy. Now, while we talk about virtual autopsy, the gold standard still remains the conventional autopsy. But the need for the virtual autopsy was felt because there was a decline in conventional autopsy, and we see a lot of difference between the developed and the developing countries. It was predominantly in the developed countries that they were finding a decline in the conventional autopsies, and also the expertise to do conventional autopsies, because you need specialized training to do all this. So then these various methods have come up. It's a postnatal MRI, whether you do a 1.5 Tesla or a 3 Tesla or even a 9 Tesla varies. The fetal brain postmortem MRI is a practice that is followed in select developed countries. And if you have smaller fetuses, you need a higher Tesla MRI. Otherwise, you do not get good data. There's also a role of postmortem ultrasound, but the accuracy is lower. You can do a postmortem CT scan for musculoskeletal abnormalities. And in really small fetuses, what we refer to as a micro CT. And this is really very good for cardiac abnormalities. So, I find these a challenge in our country, because we find it a challenge to get it done even for children because of the costs involved. But what can we do? What are the practical points that we can do if it's not possible for the family to be in a place where an autopsy is performed? Take photographs like this. Take photographs, take radiographs, detail the abnormalities instead of writing that a fetus was, delivered who had multiple malformations, because that line really has no meaning. But if you do this entire exercise, then with the help of a geneticist, you can come to a diagnosis, you can do the appropriate test, and then it's very easy to guide the families. The other thing is, if we have skeletal dysplasias, again, you do a photograph, so you see that there is a binder facies. You look at the radiographs, you look for chondrodysplasia. I mean, in this case, there's chondrodysplasia, but a skeletal diagnosis can be made from a radiograph. Or sometimes if the fetus is really small and it's a challenge to interpret this, we even do CT scans. But again, this is an expensive exercise. You only do it if there's a research project or there are no dearth of funds with that family to take everything forward. But yes, these are the basics that help in these situations. So the choice of the postmortem examination really depends first on the parental preference. We know that the conventional autopsy is the gold standard. Then we have less invasive autopsies according to what I've just shown you. And of course, then you have the higher end non-invasive methods that I hope would come in the near future, but they are very, very expensive. And then finally, we have many situations where we are not able to, give a diagnosis to the family. And this is one of them with whom I'm still struggling. Their first child, who's now, I think, 8 years old. I started with her in the pre-COVID in the pre-COVID years, where they came with this baby and severe intellectual disability, very severe microcephaly, which was of antenatal origin. I actually thought it's like God tells you that learn a lesson. I thought this is so easy. We'll quickly get an answer. She was already in early pregnancy. We didn't get an answer in her exome sequencing. In the COVID time, she continued wherever she was. And luckily for them, this was an intrauterine death because the second fetus was also affected. And we phenotyped the fetus. We did an autopsy to the fetus. We've done the MRI. We've got the entire phenotype. We've done everything for this family. I did exome sequencing for one, didn't get anything. We did exome sequencing for all 4, and then we still did not get anything. We used different capture kits to see, have we missed any part of the data? And we were looking at copy number variations. We found one that was relevant, but never found the second mutation. So it is a long journey for some families. We now know that we have to go to genome sequencing. But really what I want to bring across is that this entire bit in a very, very systematic manner is only possible when we have all this in place. Without all this, how small is the baby? How dysmorphic is the baby? Do we have imaging for that baby? All that data is required to take things forward. And then we have 3 things. What is the role of the obstetrician? And I think that's the key role for consent, because The obstetrician is the doctor, the primary care doctor with whom the family is comfortable. So if the obstetrician is convinced about the utility of autopsy, there is no reason that the family would not consent. We know that genomic testing can be a challenge without good phenotype, and there can be a change in diagnosis that can be established post-autopsy. There is a lot of data even from India to verify that statement. In the event that an autopsy is still not consented for, we would take photographs of the fetus, but with family signed consent, do radiographs of the fetus in the anteroposterior and the lateral position, and detail the external features and malformations of the fetus. And I think, though I've put it last, but in my mind, it's the most important, that we need a multidisciplinary working group, even while we do fetal autopsies. We all work together, the histopathologist, the obstetrician, the radiologist, the fetal medicine specialist, and the geneticist, to try and give a diagnosis to the family to facilitate counseling. Thank you very much.
Thank you, Dr. Ratna. It was wonderful and excellent, as usual. And I think you have opened up a lot of avenues in evaluating the fetus, not only just the autopsy, but basically you have given us an idea how to go about by dysmorphic features, a systematic approach of dysmorphic features, photographs and X-rays with the consent, because it's not that every time it's only the autopsy that's an answer, but then these are all the factors that have to be considered. And as you correctly said, that it's a teamwork, and unless we all get together and try to get an answer, it will not be possible. And most of the genetic problems are